welcome again. I am Dr. Laurel Barr. I am the chair of the Early Career Physician Section, formerly Young Physician Section. Here to talk about the forensic section with Mana Patel, their chair, and Lauren Hudak, their vice chair. Both, thank you so much for joining me today. I'm very excited to talk about this section. Another one of these sections that is kind of like a little niche that if you don't know about it, you don't necessarily know all the great things we're going. So I'd like to start by asking you to tell me a little bit more about yourself and how you got involved in the section. Monica, can I start with you?
Thank you so much for having us. We're very excited to be doing this project. Monica Patel, I'm the current chair. I got involved in a section about 2014. I was 5 years out as an attending, kind of not sure what I wanted to do yet and what to get involved. And part of my path was a little accidental. I had a very rough pediatric sexual assault case and felt completely unprepared. And coincidentally, I got a flyer in the mail about a sexual assault course for physicians in Kansas City. That was part of the annual forensic investigation conferences that were organized by Dr. Mike Weaver. I went, the course was 3 days before the actual conference, so I stayed almost a week in beautiful Kansas City, and I was hooked. I met, well, the giants of our section, Dr. Ralph Rivello and Mike Green, William Green and Mike Weaver and Sally Henning, many others. And joined the section right away, started slowly getting involved. First more as an observer, then more as an active participant. But that also prompted me to seek more opportunities in my state. I'm from Chicago. Illinois had some revisions in our sexual assault laws. So once I started getting involved, I got on a task force that was implementing the new legislation. And I undergone the same training as our sexual assault nurse examiners do. So I'm certified examiner for both adult, adolescents, and pediatric patients. I switched to academia 3 years ago and started teaching residents, started teaching medical students, and became officially a medical director of a sexual assault program, still with some involvement with state organization, nursing organization, with AAFN chapter until last fall when they started going through crisis.
So it sounds like you started getting involved in this niche area because you felt unprepared. And I feel like that's something a lot of us feel, especially in a pediatric case. These are just tragic, and you just feel like you really need to do more. So it was out of that almost ignorance that got involved. And what was it about it and the training that really drew you to this area?
It was very eye-opening how much we didn't know. And I felt it wasn't mentioned in medical school or residency. I feel maybe things are getting a little better by now, but we didn't spend enough time on it. At time when I trained was, oh, there's a kid, maybe there's a nurse, maybe there isn't. Just read through it and go through it. Learning more, there is so much to know, and I felt if I knew it all sooner, it really doesn't have to be a difficult process. It's just a matter of introducing it correctly so it becomes part of our practice. And those patients we see every day in the department, it's not just sexual assault, it's domestic violence and child abuse, elder abuse, victims of gunshot wounds, stab wounds, car accidents. There's so many times when we have to document, when we have to implement trauma-informed care that's applicable for like every patient encounter. That once you start learning what you don't know, there is a lot we can do with it.
Wow, I can just hear the passion and almost anger in your voice when you talk about these patients. I mean, it feels to me like you really want to use that ounce of prevention to prevent the pound of pain and things like that. But I can tell you're passionate just by the way you talk about this. Thank you so much for doing what you do. Lauren, how about you? How did you get involved in this area?
Yeah, I mean, I'd say a similar path to Monica. So I'm a night shift, going on 10 years, ED doc at Grady in Atlanta. So very high volume, level one trauma center, trained at Emory as well. And so I think, I had a similar path in that I've always cared care deeply for survivors of violence. So, women's health in particular. So I've cared a lot about taking care of people who've been, especially sexual assault patients. And so, we've never really had a structure, shockingly, about how we train people, and and how I was trained was, maybe a PowerPoint, and we had a session with, one of our attendings that took it on as their interest. But what I found in the forensic section is just a home of similar minded people who really care about training and teaching and how to appropriately take care of patients who have been victims of violence. And so, yeah, I think that the main thing I've gotten from this section is truly just a group of like-minded people that can share their educational materials, their protocols. And so when I started, I really wanted to change that, and I wanted to help. We needed to get NPEP for our patients. We needed to figure out how to get protocols done. And so truly, like, serving the patients was the first line there. And I've always been kind of an unofficial medical director or helper for our forensic program. But as we know, it's hard to get funding to get anything these days. And so, when I initially was proposing, it was a lot of work. Like, I had to do a lot of work with the different groups, with law enforcement, with our pharmacists, with our crime lab, all this stuff I just didn't really feel comfortable navigating. And so through the forensic section, I looked and I was like, wow, these people actually have these jobs. And oh my God, somebody pays them to do these jobs. Ooh, can I get your job description? Can I get a protocol? Can we do work on something together? And so I found this group of people really did help me find a home within that I've been able to take some of that material back to my institution and advocate for this position and, get it. Now I get, I'm the medical director of a forensic program, and it's really great. And I don't think I would have been able to do that without the mentorship and the support I've had from this section. When I first started as a new attending, I was kind of like everyone else. I didn't really know what I was going to do. I didn't really have an area that I felt like truly seated where I could put my feet and feel like I brought expertise and something value to the department. And I think through this, I really have found that and been able to kind of find my way through my career, and hopefully going forward too. So it's been really valuable to me, and I hope other members can see the value in it. Even though I know you see forensic section, you're like, what is this? What do they do? But I do think, just like Monica mentioned, injury documentation. Say you get your first subpoena for a case, our people have support for how to navigate that and help you document so that you feel really comfortable and also comfortable testifying. So there's a whole lot of benefits, maybe if you're not going to be doing it as your career, but just to be able to bring to your practice in general.
So it sounds like kind of similar, getting involved out of just a lack of knowledge or training or protocols or resources, and really trying to get involved to find those. It's not always just easy to say, here's a piece of paper, do it.
Yep.
Right. And then going back to those other things, it's easier for us to collaborate with other physicians. We at least have similar training and knowledge bases. But now you're working with laboratory sciences, forensic sciences, law enforcement, all these other things that are really outside of our training to gain their expertise so that we don't have to reinvent the wheel. So the core mission of your section: to advance forensic emergency medicine by equipping emergency physicians with practical, integrated skills to care for patients affected by trauma and violence. The section emphasized trauma-informed communication, accurate documentation, and collaboration with forensic and legal systems, improving outcomes and downstream legal and health system processes. Can either of you tell me of any examples of recent things that we've done to kind of improve those outcomes, or resources that we can find from your section?
We have a number of resources, and we've been working on linking them through our website. We have 2 ebooks, one on care of sexual assault patients and one of domestic violence, that are available for free download through the website for all ACEP members. And I really always love forensic facts that come out in ACEP now about every 2 to 3 months. Dr. Ravella and Dr. Rosai were doing them for about the past 12 years. And short half-page snippets about forensic issues. And they're also available through our website. You can scroll through and pick whatever topics, usually with photos and very clear kind of guidelines to do or not to do. So people don't have to spend a lot of time on it.
So a great resource if you're just interested in learning a little bit more about it piece by piece to kind of get some little clinical pearls there. And sounds like coming out pretty regularly so that there's an archive of it, of the recent advances and things that we can look at then.
Definitely.
Excellent. Have you been doing anything else through the college? Any papers that have been put out? Any position statements? Something that's accessible to other collaborators or organizations outside of ACEP?
Lots of section members worked on providing information on strangulation and increasing awareness about how dangerous it can be. Part of it through collaboration with the outside organization. And also we have ACEP policy and ACEP information paper on strangulation that have been released. I don't remember the date off the top of my head.
Yeah, I think that was produced really recently. I think there was also a recent council resolution in 2025 that was strongly supported and implemented in the section too to help kind of advance the care of these patients.
That's our last project that we're currently doing together with Public Health Committee.
Oh, tell me about that.
So the idea is to introduce or promote formation of interdisciplinary forensic programs. The resolution proposed creation in level 1 and 2 trauma centers, but ideally, the more ERs we can have them in, the better. Because we all know busy, especially single covered emergency physicians cannot spend 4-6 hours doing a sexual assault examination. And those patients get substandard care if the physician would be the only person having to do with it. Helping train nurses and collaborating with nurses and supporting the program would greatly improve care of all those patients and victims of violence on the documentation part and on trauma-informed care part, having someone who could spend time with them for longer and support them throughout the holiday stay would be fantastic. Not to mention that later for court subpoenas, it can free up the attending too.
I mean, that's always helpful. Sometimes my worst fear is that I'm, going to go through my shift and then have to deal with a lot of it later from whatever aspect, but also from the legal system is never one of those fun things. But talk to me a little bit more about the trauma-informed approach. Multi-collaboration, obviously the physician can't do everything. And really that's not the best care if we do. So you're putting out policies to be enacted in trauma centers, but then also that can be then put in other places as well. So what does that concentrate on to really keep the patient at the center of the care?
I can help with that one. I think it's interesting to see the benefit that forensic programs have directly for all parties. Like, I think knowing that there's going to be an advocate there to help the patient, talk them through what's happening, talk them through what to expect, and really help ground that patient to feel supported and cared for throughout this bustling, emergency department visit. And then having the trained specialty forensic examiner there to do the dedicated time and trauma-informed approach to sort of how they do the swabs or how they collect evidence, how they take photos. Like, I think that really allows the ED team and the physicians to know that their patients are being cared for just in the best possible way. And I think through the resolution, if that's able to be enacted in trauma centers, it's really going to really help our systems kind of approach patients in a way that is just the most trauma-informed we can. And then just like Monica mentioned, I think downstream, I do firmly believe our justice system is in a position to help serve our patients as well. And so us being able to feel comfortable and really reclaim that narrative in the medical record of, hey, this is how we supported this patient. Look at these injuries. This is what they've told us. And having that reflect and support them in their downstream legal issues really does is a service to our patients, and recognizing our, our DAs and law enforcement colleagues are our partners on the other side, and really trying to help them and have that narrative with them in relationship with your DA's office and your law enforcement partners, so that everyone's serving the patient in a streamlined fashion. So that resolution, I think, will really help bolster that, because all of us are fighting for that in our program. So if we have ACEP's backing behind that and seeing the demonstrated benefit, it'll really help us standardize and improve care for patients in these big trauma centers. So yeah, so I'm excited to see it.
Yeah, and hopefully where they have the resources to do some things like that, and then really showing how much it helps. I know one of the places that I work at, we have a patient advocate who will sit with the patient and kind of explain the process. And I think that's just great, because sometimes I can't really explain everything, and they're not knowing what's happening while there's long waits, waiting for labs for medical clearance and before someone can be called in, and just like explaining that and that it's normal, and then that doesn't add to the trauma process, I think is great. And other things to do and change our approaches can make all those little differences. And I really dream of a system where we don't inflict more trauma on these patients than they've already gone through, because I do feel like in under-resourced places, or just due to the nature of the chaotic emergency department, sometimes it adds to everything that's going on. And I hope that we can change that. And it sounds like you're working for that, not just through these patients, but through, child abuse, elder abuse, domestic violence, all those other cases where we really need to do a good job for these patients, and traditionally have not, or at least maybe done what we can, and now let's try and go forward and do better.
Mhm.
One of the parts of your sections that's really unfamiliar to me, just kind of working clinically, is the legal aspect of it. So can you tell me a little bit about, if I'm an emergency physician involved in one of these cases, what to expect afterwards, when you get that call that, there's something going forward, or you need to testify, or what can we expect, and how can you prepare for that?
This is perfect timing because we have our webinar. I don't know if you want to mention it, Monica.
True. That will be in May.
Yeah.
We'll have a webinar on how to be a fact witness. And we have a recorded webinar about how to be an expert witness that's also available through our website.
Yeah.
So yes, you would expect a subpoena, often coming 2 or 3 years after the actual case. And then, depending on the case, depending how good your medical record is, because that is determining were there photos or were not,
Yep.
or were not photos involved. If you're subpoenaed as a fact witness, either way, I guess working with the attorney who's issued a subpoena and finding out what the testimony is about and preparing for the testimony, knowledge of the case. Every time I've gone as a fact witness, they always want to certify me as an expert witness while I'm talking on a stand anyway. But so I think for physicians, that is a pretty common scenario.
Agreed. Yeah, it's interesting too, because the DA, so for our webinar in May, the DA I work really closely with in Atlanta for Fulton County is going to come, and we're going to talk about our working relationship of from when you get the subpoena to what to expect pre-trial, how to be prepped by your DA, sort of what to expect when you're testifying. And, it was very interesting to sort of get their perspective on why they certify people as experts, because typically you show up and you say, okay, I'm a fact witness. I'm just going to read my medical record, but I think they really want to create, and the way I love our DA says it is, I need a human. I need someone to interpret this to help me, to help this case. So that's generally why they want to certify you as an expert, is to be able to ask you a couple additional clarifying questions, maybe project about your larger experience in emergency medicine and what kind of injuries you've seen, to help interpret for the jury kind of what it is you're seeing today. Because she mentioned the fact witness is great, and that's what they do for everybody. But if you're able to sort of make it human for them, make the experience for the jury, like realizing how it was caring for that victim, what that person has been through. And so Yeah, I think the testifying can be one of those things where it's daunting, but I've loved being involved in the forensic section because of the ability to sort of reframe that into claiming it into something where I have this expertise. I'm able to serve my community and serve my patient in this other way that you wouldn't necessarily feel comfortable or feel you have the skill set to do that. And so I think, through the mentorship of the group here and our collaborations, it really helps you understand that and then be able to say, here's a fact page. Once you get your subpoena, what to expect, how you can help prep your other colleagues, when you get these cases. And, when you get your subpoena, feeling a little less that sinking pit in your stomach and more, okay, let me see what's happened. Let me see how I can help. Yeah, so I know it's one of those necessary parts of our job that sometimes is daunting, but I think it's very important, and it's important to help serve our patients in that way.
Well, and the more you're exposed to a different environment, the less daunting it becomes. So if
Exactly.
you have some experience testifying, I'm sure it gets easier and easier, which is probably one of the reasons why, we have these forensic nurses who are probably more likely than us to be out there as a fact witness. Can
Mhm.
you tell me a little bit more about the difference in these cases between being a fact witness and a expert witness as far as their implications for physician testimony or other things outside the courtroom goes?
Yeah, I'm happy to take that. So typically your fact witness, they're going to subpoena you for the care you provided specifically in that just from when you saw them and from when you stopped seeing them and just talk about the care that was provided during that aspect of the patient's care with no further conjecture about larger practice, anything else about your experience with larger patient populations. And they really do just stick to what the medical record says. So a lot of times at minimum, when you get your subpoena, you're subpoenaed as a fact witness. And so that's pretty much just that. But if they certify you as an expert, they may ask for your CV, they ask for your publications, other things. So if your DA is asking you for those things, you would expect that they're going to try to certify you as an expert witness. And so you just clarify with them during the pretrial prep, are you going to try to certify me as an expert? Because then they can ask you other questions about, say, you gave them some pain medication, and they might ask you about, like, oh, well, what kind of medicine is this? Or ask you more detail about larger practice, ask you about larger experience with, violently injured persons, or, those kinds of questions. And then on cross-examination, then the defense attorney or whomever can ask you other probing questions like that too. So you have to be a little bit more nimble if you're a expert witness. But generally, as most people, physicians who are, called to testify, we find that we're actually much more expert than you think. A lot of folks really don't know a lot about medicine, and so it gives you a chance to sort of explain things in simple terms and help you educate, people in general. So, yeah, it does feel unfamiliar, and it's a little bit strange, but I think all of us as ED docs are very nimble and able to navigate well. And so I actually think we're well positioned to be called in that way. And generally, any good prep, your DA will prep you for what potential questions you're going to have and what the cross questions might be. So just kind of demystifying that process for our providers, I think, in our docs really does help people feel comfortable when they get subpoenaed. Med mal is a totally different thing. So this is just for, yeah, so this is mostly just subpoena for care for patients.
Well, getting back to the care of the patients, Monica, you did mention that they're going to ask you a lot about your documentation, and you're more likely or less likely to get subpoenaed based on your documentation. What kind of documentation can we do as emergency physicians to help us later on? What are they looking for in that documentation?
Detail, wound description, observations, documentation of patient's affect, but at the same time, it needs to be done objectively. Because later, if it goes to court, if there's any sense that the physician was taking sides, in a way, it can affect the case negatively. So we are still objective observers, even supporting the patient 100%. We have
So
to
maybe
provide reliable information. And photos are extremely helpful here because that's our big argument for photos, especially with more EMRs having the ability of incorporate photos. So if there's anything not sensitive, like genital photos, I want to say you can put as many pictures as you can. If you can use a ruler, do. If you cannot, any picture is better than none. Because 3 years later, recalling how this gunshot wound looked, it's impossible. And it can make sometimes life and death difference or a sentence difference because was it an entrance or an exit?
Mm.
And from the picture later, it can be helpful to determine it and put it together with the story.
So a picture's worth 1,000 words. Maybe this is the time to get out that ruler and maybe spending a couple of extra minutes with the physical exam description and being objective in the documentation about affect and about what the patient says happened can really help you further on. Well, this sounds like a really excellent area of medicine from, just the need for more evidence and more evidence-based practices, trauma-informed care, and just the need for really to give the patient the best care, activating other resources outside of medicine. So, I mean, say I want to get involved in your section. How do I start going about that? What can I start participating in? How do I contact you? What can I do to get involved?
Our information is on the website. For now, we have quarterly virtual meetings. I think we just had one in February. We'll have another one in May, I think, with the webinar. And then we have in-person meetings at the Scientific Assembly that are open to everybody.
All right. And you mentioned, we talked a little bit about a preview of that May webinar. So if you're interested in more the legal aspects of this and what to expect, then sounds like we've got a whole lot more information coming. So what are you working on ahead for the next year? What could we expect to get involved in if we do get the bug and want to join?
Well, we are trying to standard for those of us that do academics and are training folks for forensic examinations. There's a few of us passionate people that are trying to get together materials to try to help improve training and work with the new. Now that many of our residency programs, I think they all are going to be going to 4 years, we're trying to figure out a way to nest a thread of forensics through that in a way that's natural, that's progressive, and thinking about content creation within our group together to pool our resources to have a nice forensic thread that we can put out for residency programs to use. And also creating an elective clinical forensic medicine elective template. So if people are interested in sort of creating that content at their sites. So that's one big thing the next few years we're going to be creating. So I'm hoping, that's from the education standpoint, that's a good thing to get involved in, that we'd love to have input and people participating.
Yeah, so if you have passion for this, then you can get in on the ground and really help develop these policies that hopefully in the next few years, 10 years, whatever, will become standard implementation in the emergency departments. That'd be great. Well, I'd like to end on a high note. Can either of you tell me a story of, someone or something that happened well because of implementation of these policies and research to really resulted in a better outcome?
So working with our department, one of our nurses who's doing her DNP project has implemented human trafficking screening in our department. And we helped one patient recently, and that was very satisfying. I don't want to go into details of what happened, but it was a very nice example.
That's awesome.
Yeah,
A chance to make a huge difference in someone's lives.
it
Isn't
definitely
that why we all went into medicine?
It is. And I know another story we had, I think because of sort of the different dynamic spaces in which forensic people work, looking and speaking, I can speak directly for Bill Howda. It helped me directly from Inova Fairfax. He's in a private group that does forensic examinations for their Inova health system up there. And I would not have been able, he sat down, took his time and energy to speak with my team at Grady to help us figure out how to structure our program through what he does. And honestly, I don't think I would have been able to get our victims' compensation funds to get patients directly financed for their injuries if I hadn't have spoken to Bill and his team. So truly that connection through this group has impacted patients and got them, reimbursed for some of these things that we didn't even know was possible. So I think that system level thing has helped a bunch of people in Atlanta and really helped us get that off the ground here. So that's one little thing, but all the all the direct patient encounters, I think truly forensics impacts people at the most personal and vulnerable times of their lives. And so by improving that, we really do impact people directly.
Yeah. And all those systems issues, like you said, you never thought it was possible. So what else is possible as we keep growing in this field?
Learning from my colleagues about interdisciplinary collaboration, kind of getting the motivation to do that. We started a SART in our medical district, the sexual assault response team. And from collaboration with law enforcement and prosecutors too, seeing those cases go all the way through and learning more about what happens after medical exam and getting their perspective was very helpful. And I feel several hospitals benefited during the past year through that. Also increasing, just exchanging information, learning how to do those things was very helpful.
Right. Knowing what differences downstream, what things we can do now that make a difference downstream to improve these patients and their outcomes. Well, thank you so much for taking the time with me today. I really enjoyed talking to you both. Keep doing up the great work. Anybody wants to get involved or just has interest in the legal aspect of it, join that upcoming webinar, and keep reaching out to the section. You can email, you can attend the quarterly meetings, and then contact at the annual meeting at Scientific Assembly to network and talk to these wonderful people who are doing just amazing things in the field. So thank you again.